Thank you, Dr. Tom Varghese, for joining the Op Report and talking today about frailty. So what is patient frailty, and how do outcomes differ for our patients who are frail?
It's a great question, Chris, and it's truly an honor to be here as well. There's been a lot of debate about what exactly frailty is. Historically, people used to associate frailty with you're getting older, so theoretically you must be frail. But then when people started thinking about it, they realized that if you think about frailty as decreased physiological reserve across organ systems as sort of the simplest definition to think about as frailty, you realize that it's a bigger problem than just our older patient population. Obviously, most of our elderly will be what constitutes the majority of the frail group. But if you think of it that way as decreased physiological reserve, you start to realize there are a lot of patients who can fit that concept of frailty as well. The bigger issue in the United States is, what to do with our elderly patient population. You and I both know that the number of patients that we operate on are continuing to increase. The proportion of elderly patients that we operate on are continuing to increase. And worldwide, the population is getting older. Some statistics that out there, by 2030, currently the population that is over the age of 65 constitutes about 13% of the population. By 2030, that's estimated to go up to as high as 20 to 25% of our patient population. Mm-hmm. And so when you start realizing those numbers, frailty is going to be a concept that's going to grow in importance in the years to come.
Sure. And as a surgeon, I've always sort of made a global assessment of a patient's frailty, and I don't remember being taught any specific criteria for what makes up frail. How is assessing frailty gone from Gestalt to more specific or validated tools?
Yeah, no, it's a great thing. The fascinating thing about the research is that it's simpler tools that are coming around. So for one example is the Get Up and Go test, which sounds as simple as it does. That is that to assess the mobility, how long does it take a patient from a seated position to get up to a standing position and start walking? That shouldn't take too long, but it's one of those things that you start realizing that by doing that in a quantified, standardized mechanism, you're able to really triage out the patient population. This goes back to, as you were saying about the Gestalt, this is what we call the eyeball test. We all do this. When a patient walks into our clinic, you're already making some assessments and observations and everything just by how long it takes that patient to come in, walk in, sit up. Oftentimes a physician will say, hey, can you get up on this examination table? And then you just watch how long it takes for that patient to do that. And so things like the Get Up and Go test are obviously just mechanisms to standardize the way that we do those assessments.
And besides the ability to get up and go, what other relevant factors are there that we think about in frailty?
Yeah, so one of my favorite acronyms to think about is something I actually heard at the recent American College of Surgeons Clinical Congress meeting, and it's the term bingo. So if you think about the different letters, B is your base. That's the number of comorbidities that the patient has. That's a way of figuring out, does this patient have decreased functional reserve across multiple organ systems? I stands for ingest or nutritional status. It's a mechanism to assess the nutritional status of that patient. And these goes back to have the patient had unintentional weight loss. You can even go through more objective parameters such as serum albumin levels or pre-albumin levels, lab values as well. The N actually is, it's supposed to stand for knowledge. I know it's not exactly spelled correctly, but in knowledge it goes back to cognition. The ability to see, do they have early signs of dementia? Do they have the ability to recall simple facts? Do they know, time, place, name, location, why they're here to come to see you in clinic? The G is the Get Up and Go test, as we talked about, the physical function. And then the O actually is something that's important to remember. It's the outside. That's what is that social function or social support network that a patient has. Honestly, that's probably something that we should be doing in every single one of our patients, not just in the frail patient or the elderly patients, because we know that there's an emerging body of literature showing that patients who have better social networks or better social support, they actually do better. There was a recent article that just came out in JAMA Surgery talking about marital status and having those patients who are married have better surgical outcomes. But the reality is that marital status is just a surrogate marker for that social support. Those patients who are married and who have this strong social support, they do better. And so that bingo acronym, that is base, ingest, knowledge, get up and go, and outside, is a framework that can help you remember how to assess for frailty.
Sure. And so what are the factors we can mitigate? How do we prepare someone for surgery?
And this is where
get them married.
Get them married. No, I don't advocate for that. I think that this is where there's going to be increasing literature and increasing studies coming along. It's well and good to tell a doctor, it's like, yeah, you've got a frail patient, they're going to do badly. Most physicians will say, yeah, I know that. I can eyeball the patient and say, what can I do about it? I think that what we need to do is a twofold approach. One, we have to standardize the way that we assess patients. That is, we have to standardize the mechanisms to make sure that we're doing these frailty assessments in every single one of our patient population, and not just make the assumption that it's the elderly patient that's going to be frail, that there's going to be a lot of different types of patients that are frail. Second thing is that once we do those identifications, really drive in and do specific interventions for each of those parameters. So if the nutritional status is poor, can you link that up with your nutritional experts, dietitians, nurse educators and everything in clinic, and get that intervened well before the surgical intervention. Same thing with functional fitness or the get up and go test. If you have somebody who's frail, there are other parameters, things like grip strength is talked about as well. But if you have a patient who's frail, maybe it's don't sign them up and take them right away to surgery. You may need to pause a little bit and get things like physical therapy and other things involved as well. And then the social function. That's sort of a little bit of a messy metric, as you jokingly said about getting them married. But, what do you do with a patient that has absolutely no social network at all? Is there something that we can come up with in terms of an intervention? I think that's going to be the emerging evidence in years to come forward. I think that we're still, unfortunately, right now in the early phase of how do we identify frail patients and making sure that's systematically captured in every one of our patient visits. Years ahead are really going to come about with further programs, specific interventions so that we can address this in real time. We have to do something, because if we don't, the poor surgical outcomes are really going to be the norm rather than, the exception.
Great. So let's talk about the very related subject, just the 1 minute bit on Strong for Surgery, which we'll talk about in another video.
Sure. As you know, Strong for Surgery was a program that was launched in 2012 in the Pacific Northwest. And as of 2 weeks ago, is now a formal program of the American College of Surgeons. And literally all it is it's a change platform where the goal is identify these areas of risk preoperatively and then do the specific interventions to optimize health prior to elective surgery. So don't just make the note of, I'm going to sign this patient up to surgery and take them right away. Pause for a second and say, is there something that I can do to make this patient strong for surgery? And if there is that mechanism, to go ahead and go forward with that.
Very good. Final words on Frailty or Strong for Surgery?
Absolutely. I think that it's something that has been known for surgeons in the surgical community for a long period of time. We know that, obviously the sicker your patient is, the frailer your patient is, they're going to do relatively poorly. But there are specific measures to make sure that we can standardize this for every single one of our patients, and there are specific interventions that we can do. What we need to do as a surgical community is design better implementation tools or better intervention tools so that we can capture this in every single one of our patients and then do those specific interventions to improve the health of our patients preoperatively as well as postoperatively as well. That is, taking that moment to optimize their health before surgery will drive better outcomes going forward.
Thanks for your time, Tom Varghese.
Thanks so much, Chris. Appreciate it.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.